Hello and welcome to the 2019.2 protocol update. Start off by showing you the memorandum that came out. It starts off by referencing the Massachusetts Department of Public Health Office of Emergency Medical Services, and it speaks of the new changes that are coming along with the protocol updates, such as glucagon coming to the EMT providers, as well as Atrovent. Basically, this memorandum states that the glucagon is being approved because of how successful the check and inject program has become, and it's been adopted kind of across the board, across the state, in many agencies, and it's being very successful. Protocol 6.10 is now a medical director option protocol. Service may implement it as soon as it's approved, and basics will be able to go ahead and give glucagon once the training is 100% complete to all employees. Alright. Move on. This is the protocol change sheet, which you're going to be able to find right online when we get in the notes. We're going to kind of walk through this. As we do, we're going to be looking at the protocols as well, so that we can make sure that we hit everything. Alright. So, first change is going to be that the title change for BLS bronchodilators, adult and pediatric protocol 6.1, which is the medical control option. The title change is going to check and inject epinephrine by the EMT basic. It used to be BLS provider, so just standardizing some language kind of across the board so that it's consistent. Next is a title change. A hyphen was removed. EMT basic now reads continuous positive airway pressure. In parentheses, CPAP by EMT basic and or advanced. And then glucagon for hypoglycemia by EMT basics, protocol 6.10. They're going to be able to administer that intramuscular as a medical control option. That'll be an additional training, about an hour long, that's going to be coming out in the near future. Next change, protocol 2.3. So let's scroll down. Altermental neuro, diabetic, and coma for adults. Third bullet is now going to read glucose or glucagon are indicated only for documented hypoglycemia. If authorized and trained to do so, obtain a blood sugar reading. So go to our third bullet here. We're not going to be administering glucose or glucagon if it's not indicated. New language in the basic section reads if patient is unconscious or unable to safely swallow, and if approved, they're going to be able to administer glucagon 1 milligram intramuscular, rechecking the glucose in 15 minutes. They may repeat that another milligram after the 15 minutes if their blood sugar continues to be less than 70. So you can see that change here at the bottom of the protocol. For protocol 2.3p, here for the pediatric population, in the EMT section, they did make a change here as well. If you remember in the last protocol update, we talked about them making a weight-based dose. They have since changed that to make it a little bit easier on everybody. Now oral glucose is going to be a half a tube for a patient under 20 kilos or a full tube over if they're over 20 kilos. And remember, other sources of sugar are always going to be accessible. So if you can't get a child to eat the tube of glucose, you can always try giving them a snack that they're familiar with and that they enjoy. Next change, we're going to go to protocol 2.6. So this is for bronchospasms, and in this protocol, the update EMT basic medical control section, the language has been added for epinephrine 0.3 milligrams via auto-injector if it's approved under protocol 6.6, check and inject epinephrine by the EMT basic. So at our agency, we are only allowed to do this because we already have implemented the check and inject training. So EMT basics are now going to be able to administer 0.3 milligrams intramuscular for severe bronchospasms and asthmatics. So if we just take a quick look at the protocol here, right down here at the bottom, Um, the maximum dose has been administered prior to arrival of the EMT. The patient cannot physically use the device properly. The device has not specifically been prescribed by the patient. And then here at the bottom, if properly trained and authorized, use protocol 6.1 dealing albuterol. Next, down below that, you see the CPAP, which has been added. But then now there's this new section under medical control order for the epinephrine here. So 0.3 milligrams via auto-injector, if approved under the protocol 6.6, check and inject. They may deliver intramuscular, not via auto-injector. So our EMTs will be able to draw it up and administer 0.3 milligrams of epinephrine for bronchospasms if medical control orders that. So you will have to call. Remember, for EMTs, you're going to be activating a signal 300 when you contact medical control. In the paramedic section, magnesium sulfate infusion time has been increased to 20 minutes. So it used to be somewhere between about 5 to 10 minutes for mag sulfate. Now they've increased it to 20 minutes. There's a lot of reasons for that. Mostly because the magnesium can be pretty volatile to the veins. It causes a lot of irritation and a really severe burning sensation. So it's a lot safer to administer it over a slower period of time. The dosage is going to be 2 to 4 grams. So if you just put that into a 100 ml bag and run that in over approximately 20 minutes, you can do some pain-free there and continue treating your patient otherwise. Would like to add that the protocol does specify for asthma only, so this does not qualify for your COPD patients. I'd also like to add that magnesium sulfate may have other side effects if administered too quickly, such as hypotension and bradycardia. Okay. Moving on to our next section, we have protocol 2.1 for OB, 2.13 for pain and nausea, 2.15 for seizures, 3.1 for acute coronary syndrome, 5.2 difficult airway, 7.6 for sedation and anesthesia. There's just a minor change. The word slow has been removed from fentanyl administration and or midazolam intranasal dosing. The routes were separated out now so that it says slow IV, IOIM, and IN. Slow intranasal has been determined to be ineffective. Part of the reason is because the medication does not properly atomize. So when you're giving intranasal medications, you need to push it really fast so that it maximizes the medication's ability to truly atomize, which will increase absorption rates in the nares. Just like to remind everybody that when you give intranasal medications, you should not administer more than 1 milliliter per nostril, and then you need to give it several minutes before you can administer another milliliter into that same nostril. Moving on to the next section, 2.13 pain and nausea management. Let's go on to that protocol. There we go. Okay. In the paramedic section, dose ranging has been changed for ketamine. So in the ketamine class, we discussed pain ranges, and we discussed that really saying between 0.1 to 0.3 is going to be your most effective pain dosage with the least amount of side effects. The state is now saying that larger doses are more effective for pain. A lot of the research that's out there still is recommending 0.1 to 0.3, but we're going to stay within our protocol. My recommendation to all of you is that your initial dose would be 0.3 milligrams per kilogram. Stay on the lower end, and make sure you're pushing it nice and slow. Again, you can put it in a 100 bag and run it in slowly and have similar effects to morphine in terms of pain management. Giving those a little bit of a larger dose can cause a lot more side effects, more hallucinations, and increased risk of sending them into the K-hole, which we already discussed. Moving on to the next protocol, so 2.14, poisoning, substance abuse, overdose. They have removed subcutaneous route of administration for glucagon, and they've determined that it's kind of ineffective for the route of administration for glucagon. So you can see that down here. It's no longer there. Okay, moving on to protocol 3.3 for bradycardia. In the paramedic section, ashpine, the line minimum single dose of 0.1 milligrams has been removed. This is actually in the pediatric dose. And it's been removed to comply with AHA standards and recommendations. So now the dose will just be 0.02 milligrams per kilogram to a maximum single dose of 0.5 or PD patients. We don't want to go over the minimum adult dose. And if increased vagal-tone or AV block is suspected. The next protocol change is going to be in protocol 3.5A for VFib and VTAC arrests. And this is going to be kind of a bigger change here. So in the paramedic section at the second bullet, the defibrillation language is now reads defibrillation when available with minimum interruption in chest compressions. Use the maximum manufacturer's recommended energy. Then high quality CPR for 5 cycles or 2 minutes. Then rhythm check. They want you to now charge your defibrillator while performing chest compressions to minimize hands-off time. This is the perishock pause that we have been implementing since Victor CPR. The state's now catching up to it and has realized that it really cuts down significantly on your pauses, decreasing it, keeping it under 10 seconds when you have rhythm identification. So we're really maximizing the ability of our crews to do high-quality CPR with these patients. Along with that, they have removed at the fourth bullet 360 joules monophasic equivalent, and this language was added. Continue high-quality CPR and defibrillate each shock at the maximum energy recommended by the manufacturer per ECC guidelines if ventricular fibrillation/pulseless ventricular tachycardia is persistent. So, due to the many options, the language was changed to use the maximum manufacturer's recommended energy. So with the LifeHack 15, that now means that with VTAC defib arrest, we're going to be defibrillating at 360 joules. We're no longer going to do 360 with our shocks. We are going to be looking at the monitors and the way that we set it up to see if it's a possibility to initiate the shocks at 360, which I believe it is. So stand by and keep your eyes out for an email in regard to that. Okay, so moving on to the next 4.5, multi-system trauma, adult and pediatric. Here we go. This information has been removed from the paramedic section. For a patient greater than 16 years of age who has a systolic blood pressure of less than 90, a pulse greater than 110, or if the provider determines the patient to be a high risk for significant hemorrhage, TXA 1 gram IV over 10 minutes. This is a technical fix. TXA in trauma is a medical director option, not a standing order. As a service, we've already gone through the TXA training, and we have it on the trucks. We are allowed to administer it. We have approval. It's in our affiliation agreement. This is still a TXA is still in the protocol, and if you look at the system here, you can see down here in the note section at the bottom, service medical director option for use of TXA only if trained and authorized. See protocol 6.5, which is specific to TXA. So if we then go down to protocol 6.5, we can reference that. All right. So there are some changes here with the TXA. Patients with blunt or penetrating trauma mechanism suffered in the past 3 hours who appear aged 5 or over, so they've lowered the age range, shows signs of significant hemorrhage, systolic blood pressure of less than 90, heart rate greater than 110, or if the provider determines the patient to be at a high risk for significant hemorrhage. So they're still kind of leaving it up to us to administer that. Pregnant trauma patients and trauma patients on blood thinners are eligible. TXA, the dose has now changed. It's no longer a gram as a standard. It's now going to be